In the United States, we really have 50 shades of graying, from people who age very gracefully to ones certainly not. And it has created a major challenge in the medical field. And I am with probably one of the more exciting people that I've talked to for a while, because I've really enjoyed her presentation here at the CV Summit in Las Vegas. Cynthia Richardson is an RN BA, and your title is Level 1 Vascular Emergency Program Coordinator. And this is from Indiana University Health, the Level 1 Vascular Emergency Transfer Program. This is something that has a variety of applications to a variety of different settings. First, let's go back 5 years. How did this whole thing start?
Well, we had a rather robust STEMI program. We had a process of bringing those in very quickly and getting them through the barriers that are usually standing in place when a patient's coming from point A to point B. With that first program, the STEMI program, we were able to look at that and see how that was running so well. We thought, because we had struggled so long to get the aortic emergencies in a timely manner, we thought this would be a great vehicle to put into place to get these patients in a more rapid process. So we took that on, looked at the algorithm, knew that we could tweak it a little bit and apply it to aortic emergencies. And that is basically where we started.
So it's the quality metrics that you're interested in. It's the getting patients to where they have to be, the emergency patients, fast, not running through the ED or sitting in a lounge somewhere waiting to be seen.
That is correct. We want them into treatment as soon as possible.
So what are you doing? You have, I think, several programs now, but how is this working on a day-to-day basis?
It is working very, very well. We have settled into this process. Everyone knows their role in it. We do the same, try to do the same thing every time. The activation, starting with a nurse in the transfer center, she is the pivot point and the intake person. And she stays engaged in that transfer process until that patient arrives at Methodist. There are certain points that she's updating the team, or if she gets more information, she's putting the surgeon back on the phone as rapidly as possible. The whole basis of this is to get that burst page out and the appropriate specialist on the phone and as quickly as possible. And as we've settled into this process, that is happening anywhere from 1 minute to 3 minutes.
You have a variety of different programs now, not the one you started with. You have, I think, a total of 5. What are they?
They are the STEMI program that we started with. Next came the Vascular Emergency Program. In between there, the trauma team came and touched base with us about the process and applied that over to their division. We now have Level 1 Esophageal Emergency that is addressing perforations of the esophagus for whatever reason. We now have Level 1 Cardiogenic Shock that went live last month, and it's looking like it's starting to gear up. And within the next couple of months, we will be Level 1 Pulmonary Emboli. And we look forward to see how that rolls out.
Back at the beginning, when you were having great success with STEMI, were you noticing that there are other patients who are just hanging around the ER much longer than they should? I mean, was there really why wasn't this patient seen earlier moment that helped to trigger this?
That was something. We had always struggled with those patients coming in after they had sat in an outside ER for 6 hours, 10 hours. Very, very long time. For something in the evaluation process didn't trigger them to look at the big ugly monster sitting over in the room. Now we try to, with this program, we've tried to emphasize that, rule that out right off the bat, then go back to what other possibilities there could be. But the sooner we get these into treatment, the sooner we get that phone call, the better we're going to do for the patient and send that patient home.
You seemed really successful, really fast, almost surprisingly so.
It was. We did not expect this type of volume right off the bat. And to have an increase by 200% in the first year, that was a bit of a shock.
That can stress the staff.
It did stress the staff. It did cripple our OR. We very quickly needed to go back, look at the process, not really the process, but the program, and how are we going to support this and not lose our good people.
And this is something that isn't now just right around your hospital, but you're really taking people in from all over the place.
We are taking them from all over Indiana, and we've got 4 sites in Illinois that send to us when they need to, a couple in Kentucky and 1 in Ohio. So we have spread out past our boundaries.
Now, what about marketing? Was this a major challenge for you at the beginning?
We had budgeted for marketing, thought we were going to need it. We did not use it. We used a couple $1,000s. It was mostly just making materials to give out as quickly as we could. It really spread by word of mouth. And something about the emergency community, once they find out something is going on somewhere, they spread it very, very quickly. And that is really where we discovered our referral base was coming from, were emergency departments. In the beginning, we did not think it would be that. We thought it would be cardiologists or someone else or a family practice. And we sort of went in that direction, but we very quickly changed directions and focused on emergency rooms.
What are the main lessons that you would like to offer to others who are listening and going, this is probably applicable in more states than Indiana?
Mm-hmm. We feel that it is necessary to get these programs built to meet the need in the community. It's not just our state that has this problem. So we are really wanting to get the word out, how this can be done, and are willing to work with others to get those programs developed out there.
And in terms of staff training, and obviously they're involved because they're so busy, but I mean, did you have a lot of staff resistance at first, or was this something like a V8 moment? They just slap their heads and go, why didn't anybody think of this before?
The V8 moment came much later after they had tried it out. They were skeptical in the beginning, just like they were with the STEMI. They were not convinced that this was going to work. They'd done it one way for a very, very long time. We probably had about 2 years there that we were talking and encouraging, just try it once. And once they tried it 1 or 2 times, they saw how much easier it was than what they'd been doing their entire career. So the aha moment came later. We had to encourage, and like I said in the previous workshop, we sort of did a reward system just to get their attention and keep them engaged. And we say that the level 1 programs are built on candy bars, car washes, and movie tickets. When they meet their benchmark, we're out there with the rah-rah and the candy basket, and everybody gets a treat.
I like that a lot.
But, it's the same for adults as it is for children.
Yes, absolutely. So again, we're at the Cardiovascular Summit here in Las Vegas for 2014. Please see our coverage in CSWN as well as online. For CardioSource World News, I'm Executive Editor Rick McGuire.